really keen to share my experiences with you. However, my slides are not going to move on. Just took time. Okay, so as we've already heard from Rama, this is a progressive, severely debilitating and ultimately fatal lung condition in the categories that I've listed above. So UIP, commonly known as IPF, is a specific type. It stands for usual interstitial pneumonitis, and that is the specific type of illness that Ron was talking about that tends to happen in the elderly men. I would go a little bit further to say most of them are quite tall and slim, and have actually been professionals in their life and really like to stay in control, which can be really difficult in this condition. And as a consequence, we cope with lots of adjustment disorders and anxiety relating to their illness and their symptoms. NSIP, as Rama said, there's some overlap with connective tissue-related ILD and hypersensitivity pneumonitis. Those are the three subgroups of pulmonary fibrosis that we tend to see most of in our pulmonary fibrosis support group, because these are the conditions that tend to progress most rapidly. We've already heard about the poor prognosis, and that there is relatively limited treatment, especially for IPF or UIP, to slow disease progression. For some patients, these antifibrotics can be fantastic and can slow down the progression of the disease. But for many patients, and we looked at the patients in our pulmonary fibrosis support group, they can be very poorly tolerated, almost to the same extent as chemotherapy in some patients. But stopping the antifibrotics holds all the same moral and ethical issues around patients worrying about if they stop them, the disease will progress faster. So we have to be really careful about the way we talk to patients about the importance of maintaining their quality of life when they're suffering terribly from the side effects. And as I've already said, it's a potentially very symptomatic, distressing death. Whatever the etiology, between those three subgroups, the symptoms are generally the same. Patients are often already very symptomatic by the time that they are diagnosed. And I would say prompt referral to the palliative care specialist service at the hospice is almost always appropriate, but referrals were rarely made when we started this work. And the reason I say that prompt referral is important is that we can bring the patients in, we can assess them, we can do a holistic review, we can manage their symptoms, and then they can dip in and dip out as they need us. We don't have to keep them on our books and review them regularly. They can dip in and dip out, but often people find the peer support and the professional support through our group extremely helpful. This is not a criticism, this is absolutely necessary, but the focus in the ILD clinic at local level and in tertiary centres is very much about pulmonary function tests, CT scans and drugs, with little discussion about symptoms. And Rama and I have been trying to work with the team to change that and really flag up when people are symptomatic and try to get them referred to us sooner rather than later. For UIP, it's often unfortunately a very predictable course, and that can be very rapid. For the other subgroups, for NSIP or connective tissue disease-related pulmonary fibrosis and NSIP, the course can be very unpredictable, but that can be rapidly progressive. These pictures really sum it up for me. What does it mean to the patient? They talk to us about the feeling of suffocation. They can't take a big breath in. They are struggling to breathe. They're having to work really hard to breathe because they've got this lump of concrete in the bottom of their lungs, which means they just cannot get enough air in. And I was looking for a long time. We have a patient on our inpatient unit that I'm going to do a case study on shortly. And I was with him the other day when his oxygen saturations dropped to 49%. I have never seen terror in somebody's face like it. His eyes were practically popping out of his head. He was absolutely incapacitated by terror. That's the nearest picture that I could get from the internet, which gives us an idea of the terror that these people feel. And he's not he's not constricted with an oxygen mask on his face. Some time ago, we looked at the different symptoms because, yes, the patients do have breathlessness. They absolutely do. It's pretty much uniformly present in every patient. But look at all these other symptoms. Ron has already mentioned cough, but they're often anorexia, whether or not they're anorexic, whether or not they're on antifibrotics. It seems to be a manifestation of the disease, and I wonder whether this partly to do with the cytokines that are released during the fibrosing process. Immobility is a really big problem. Often patients are extremely fatigued, again, probably due to cytokine release. They're often constipated, especially if we've got them on some opioids to help with their breathlessness. Sometimes they suffer from indigestion, and sometimes, often, because they just cannot get to the toilet in time, they will be incontinent. In terms of psychosocial issues, not to be forgotten, anxiety and panic is present in nearly all patients. Adjustment disorders. Often these people have been really fit and active right up until their later years, and suddenly they're completely incapacitated and they just don't know what to do with themselves. They find it really difficult to adjust to being dependent on other people and not being able to perform what they feel is their role within the household. And supporting them through that can be really important. Depression is not uncommon. People present with intimacy issues, confusion, and often loneliness because they're not getting out of the house anymore. What about the carers? Now, this is the really important part of what we do. And Hewitt will talk about this a little bit later. But they express difficulties in adjusting to the role in caring for these people. They tell us they struggle to cope. They feel overwhelmed and emotional. There is nothing like seeing somebody that you love struggle to breathe. I witnessed this with my grandmother, who in fact was dying from heart failure, and the feeling of helplessness when somebody is in the middle of a panic attack because they can't get their breath is really difficult to witness. They feel exhausted because they're doing everything, and they feel frightened about what might lie ahead. So supporting the carers is a really important part of what we do. So what does good care of patients with ILD look like? Well, obviously, care of the underlying condition with close monitoring and input from the respiratory teams, looking at their pulmonary function tests and intermittent CT scans to see whether the disease is progressing or stable, to consider whether or not we've got the right diagnosis, and to think about adjusting treatment if that is appropriate. But alongside that, we need to have good symptom control. We need to be able to have honest conversations with the patient, but they are in control over how much we tell them. We must, in my opinion, avoid a false hope. There is nothing worse than trying to be kind by not telling the patient the truth. We need to be compassionate and kind. We need to do holistic assessment, and we need to care for carers. How are we going to achieve that? And I suppose one of my biggest take-home messages from today would be go back to where you work and make friends with the other teams, okay? So if you're palliative care, really develop your relationships with people that look after people with pulmonary fibrosis. And if you're working in respiratory, make friends with your palliative care teams. I'd always be happy to talk to your palliative care teams about the way that we have progressed this work at St. Francis. So just rattling through the symptoms, we've spoken about breathlessness is often associated with low oxygen saturations, and I say often increases, always increases over time. It's not always in keeping with impairment of lung function because disordered breathing as a result of anxiety can also impact on this. It's much worse with high levels of anxiety, but it's terrifying for the patient and carer, and it leads to anxiety about what lies ahead. What can we do to help? Well, there are lots of non-pharmacological breathless management techniques, and I think Anisha will come on to talk about this a bit more later, so I'm not going to dwell on it. But in terms of drugs, morphine is your best bet. My advice would be, especially if you're dealing with elderly people, to start low and go slow. And I will often start with 2 mils of oral morphine liquid just twice a day. Especially if you've got someone who's frail and elderly, and then gradually titrate up. Got someone a bit more robust, I'd start them straight on MST 5 milligrams twice daily. But when I'm assessing a patient, I will be trying to assess which is the most important problem. Is it breathlessness due to the underlying condition? Or actually, is it anxiety that's provoking the breathlessness and triggering panic? Because if I think anxiety is the bigger problem, I will start, rather than going for morphine first, I would start diazepam, again at low doses of 2 milligrams twice a day, and be prepared to stop it if the patient can't tolerate it. Cough is really, really difficult for patients. It's generally a dry, non-productive cough, and often takes the patient over in spasms and is completely uncontrollable. It's totally exhausting. It leads to a massive fall in oxygen concentrations. It's embarrassing, so patients won't leave the house because they don't want to have a coughing fit. It's very debilitating. Patients can develop cough syncope and they feel like they are going to die. Sometimes it's associated with asymptomatic reflux. We can treat the reflux with proton pump inhibitors and H2 blockers. We can try cough sweets. They don't generally work, but can be a bit of a distraction. I often find that saline nebs with this dry cough, and I often suggest trying those in the morning when the cough is worse, when the patient has been lying relatively flatter and hasn't been clearing their chest during the course of the night. Morphine is a good cough suppressant. My observation would be, and I have no evidence for this at all, is that often cough gets better as the disease progresses. Anxiety and terror I've already spoken about, and I don't apologise for speaking about it again because it's such a big problem. And like I've said, they worry that they're going to die during an episode of breathlessness. One of the things that I will do is reassure them, if you can use that word, that this will not be the case, that when they have these panic attacks, they are not going to die. That is not likely to be how it will happen. So we need to treat the breathlessness using the drugs I've already mentioned. We need to allow the patient to express their fears and to offer reassurance about what we can do, not only to manage the anxiety when we first meet them, but also about what we can do later on in the course of the disease. We can use cognitive behavioural therapy to help people cope. We can use breathing control techniques, and a particular favourite of mine is visualisation, where you encourage the patient to take themselves away to their favourite place. I always talk about my favourite place being on the top of a mountain, and then I talk to the patient about what I would see, what I would hear, what I would feel, what I would smell on the top of this mountain. And by the time you've been through all that, if you can take yourself away from the breathlessness, the panic attack will have eased. This is, sorry, it's so Heath Robinson, but this is a picture I often use with my patients. So the bottom line is, I explain to patients, this is where my anxiety level would sit. And if I have something that makes me anxious, I will have a little bit of a blip and then it'll come down again. But the top line is where a patient sits, just below the level of anxiety that triggers a panic attack. And what I explain to patients is that I'm using diazepam or other benzodiazepines, and I like to use the diazepam regularly to bring this level here, where the patient sits, down, so they have further to go before they reach a panic attack. And that explanation seems to work really well for patients. Anorexia and weight loss, I've already mentioned that this can be due to the underlying condition, but it is definitely made worse by drugs. And, I do know, intellectually, I know that these drugs are great for some people. Take Grandma's father, for example. But I also know that so many patients are so very ill on the drugs, and helping them to understand and see this and stopping the drugs is really important. I think it's very helpful that we have this guideline that if you lose 10% of your weight, the drugs should be stopped. As the illness progresses, it becomes more difficult to breathe and eat because you're so breathless, and often people are having to wear Venturi masks, or at its worst, masks with non-rebreathing bags on, and if they have to take the mask off to eat, that becomes much more difficult. And the work of breathing burns additional calories, which also contributes to the weight loss. So we need to encourage high calorie intake. We need to review the drugs. We need to get dietitians' input and get dietary supplements in place and encourage snacking throughout the day, eating little and often as high fat as they can possibly tolerate. I have to say I'm a big fan of dexamethasone, and I've come up against some of my respiratory consultant colleagues regarding this because there was a paper some time ago published in the New England Journal of Medicine that said that steroids weren't the right way to go because they caused immunosuppression, and then patients got sick and got infections and then deteriorated and died. But you only need to have given dexamethasone to a few of these patients who are losing weight hand over fist and seen the dramatic improvement in their quality of life to know that this is the right thing to do when it's the right time. In terms of psychological issues, the patients feel like they're being a burden. There's an increasing reluctance to do things. Often we find that they're reluctant to accept the use of oxygen, and they're reluctant to use a wheelchair, and they fail to adjust to this loss of function. Our challenge is to provide the tools to help patients and carers live with the illness as well as possible and not to frighten them. People say to me, if I use oxygen, I'm giving in to the disease. If I use a wheelchair, what's the point? I'm just giving in. And I say, actually, I'm going to challenge you on that. Because for me, by not using your oxygen and therefore not being able to do the things you want to do, by not using a wheelchair to get out of the house, you are giving in to the disease. And I challenge you to turn this on its head and to fight the disease and say, I'm not going to let you stop me from doing the things that I want to do.
Sharon, just a couple of minutes.
Sorry, how many?
2 or 3. 3.
Okay. Look, I'm gonna flip right through to the end and show you this picture. This chap is a chap that I saw in Watford Hospital. He has a connective tissue related lung disease. And when I first met him, he was on 15 litres via non-rebreathing mask, plus 5 litres of oxygen via nasal cannula. He was absolutely panic-stricken. He spent 3 months in hospital, the last 1 month in Watford, 1 month in the Brompton, and 1 month again in Watford after he caught influenza A, unfortunately. He couldn't move. He was overwhelmed with panic. This is the chap who desaturated to 49% trying to use the commode. He came to the hospice. We have the time and the space and the less busy environment to help him to come to terms with what's happening. His transfer was delayed by this false hope of him being able to go onto the transplant list. He was told that if he could stay stable at home for 2 weeks, then he could go and have an assessment for transplant. He can't lie flat. He can't take his oxygen off to do lung function tests. He can't have all the investigations he would need. He was never going to get a transplant. Once we told him that, and he was able to accept it, we were able to bring him over to the hospice. And this is a picture of him with his partner at the hospice. And we've actually started him on Optiflow, which is a whole new ball game and is going to